This is just a brief introduction to the UC Davis 10th Annual Quality Forum. If you read the text in the lower box, the effort behind this is to engage our trainees in particular, and along with that, have them have mentors to understand what quality is within the healthcare system. And the idea behind it is the classic learning healthcare system, which is we study something, we investigate it, and we learn from that, and we make changes. And those changes result in continuous improvement in our overall quality. Let's see, how do I forward this? There it is. This program was started in 2016. It's funded by the Office of the Medical Director, and it's particularly aimed at supporting curriculum development and quality assurance. It encourages the learners, our residents, fellows, trainees to participate in different quality improvement programs with, of course, faculty mentors, and it's meant to continue to grow. Its really aim is to support program directors that have in every one of our training programs to try to engage their trainees, their residents in quality improvement projects. And in doing so, cultivate hopefully future leaders in this topic in the healthcare field. And of course, that's the goal behind this. So what we have is $56,000 to distribute. It's given out in 8 different proposals, awarded $7,000 each. And money is theirs to use as they see fit. It goes to the program director to use for this project. In addition, there's another $16,000 that's given out for particularly high value awards. First, second, and third award is listed here. And this has been going on now in its 10th year. As a result, this is the last 6 years. You can see how many proposals were put in by departments. Anesthesia has 21, internal medicine has 50, and surgery, a bold 57 different proposals while doing. Winning proposals, we have 12, internal medicine has 13, and the end-all over quality winner, we've yet to achieve that goal, but don't worry, it's going to happen. So this year, the 8 winners are listed here, and of those 8, 3 are from surgery. And I wanted to take this opportunity at Grand Rounds to let these 3 highlight their projects along with their mentors for comments on what these 3 have geared us for in terms of quality improvement programs. I think we'll start at the bottom. Jennifer Geiger will go first, then Ashley Ruff second, and then Keith White third. So I'll turn it over at this point to Dr. Geiger with Misty Humphreys as her mentor. Jen?
Good morning. Thank you, Dr. Jurkovich. My project is towards earlier goals of care, implementation of the ACS TQIP palliative care guidelines. And this project was really born out of my clinical experiences as a resident at UC Davis, facing what I felt was daily challenging communication barriers with complex patients and often, facing surgical emergencies. Susan Block, she's a palliative care expert. She said a family meeting is a procedure and it requires no less skill than performing an operation. And my best guess is a lot of us don't share that perspective as surgeons in this room, but my hope is that with more weight put on communication and addressing it in a systematic way, we could help improve the alignment of care for seriously ill surgical patients. My primary mentor for my academic time is Dr. Humphreys, and for this project, I have a great interdisciplinary team with a lot of palliative care trained surgeons, Dr. Curtis and palliative care docs from the UC Davis team, Doctors McMillan and Fairman, as well as some other key champions in the department that have been very helpful. Trauma and ACS patients have a very high burden of palliative care needs. Just to quote one statistic from the literature, 20% of patients aged older than 65 who undergo emergent abdominal surgery die within the first 30 days. So reflective of this, the American College of Surgeons Trauma Quality Improvement Program published palliative care best practice guidelines in 2017, really just promoting concurrent primary palliative care alongside trauma care delivery. And these actually made it into our trauma guidelines in February 2020, but they haven't really been operationalized in any sort of systematic, standardized fashion. This is very preliminary data. It does not tell the whole story, but highlights some room for improvement. Last year, there were about 100 non-hospice inpatient deaths on the ACS and trauma services last year, of which just over a third had palliative care consults and under half had comfort care orders instituted at the time of death. What are the TQIP guidelines? This figure highlights the key messages. So they are recommending that we complete a palliative care assessment for all patients within 24 hours of arrival into the trauma bay within admission. And what this means is the first part is identifying a proxy decision maker for all patients and addressing any pre-existing advance directive or PULSE or DNR orders the patients might have. And then the other essential piece is early prognostication. So all patients, they recommend, should be screened for palliative care needs. One tool they offer for doing this is called the surprise question, which a lot of you may have heard of it already. This is just a gestalt question that asks you to look at the patient and say, would you be surprised if this patient died in the next 6 to 12 months? If the answer is no, you would not be surprised. Or if a patient falls into other categories of high risk for poor outcomes, such as advanced age, frailty, the presence of serious illness, and the obvious one, life-threatening trauma, then they recommend those positively screened patients undergo a goals of care meeting within the first 72 hours of hospitalization. And then for the patients in that most high-risk category of even potential mortality during the hospitalization, they additionally recommend the adjunct of early palliative care consult. So what I propose for my QI project is an intervention that puts these recommendations into practice through what I'm calling a palliative care communication bundle, which has 4 key parts that would be first piloted in the ICU patients for the acute care surgery and trauma patients. And that is identifying pre-hospital preferences upon admission, triggering goals of care meetings and advanced care planning through an EMR palliative care screen, documenting discussions in a standardized fashion in the EMR, and administering the training to do this. So offering some mild training in primary palliative care, communication skills, as well as communication. How do we do this? Well, the really exciting news for me and why I think this is a feasible project to be undertaking right now is the wind is already at our backs, in a sense. There's an ongoing system-wide initiative that the hospital has been taking that's very supported by high levels of leadership called the Mandatory Surprise Question Project. And this has a lot of parallel goals. The main concept is it's using IT as a launching point to better identify patients at end of life or who might need advanced care planning. And they've developed a couple awesome IT tools. The first is that they are building in the surprise question into admission order sets. So they first piloted this in the hospitalists, and that makes it sort of a mandatory step and could be something then co-signed by an attending. They also created something called the Advanced Care Planning Navigator, which a lot of us are probably unaware of. Ever since the conversion over to Storyboard, this tool has become a little more accessible. Down here under the code status, you'll see ACP docs. You click on that and it opens up what's really a central repository for all things advanced care planning and goals of care. So they pull in healthcare proxy and their contact information. They pull in all advanced directives and PULSE that might be available in the chart, where previously it was hard to kind of find where these were put in a systematic way. They've created a template for serious illness conversations that you can fill out and pull in as a dot phrase. And then there's also an open section notes for tailored dot phrases. The other really exciting thing is they've hired 2 social workers exclusively for this work and additional inpatient hospice staff. So there's really a lot of resources at our disposal. Once implementation is more underway, how will we know this is making an impact? Well, in traditional QI design, it's not, going to be a clean-cut pre-post research study design. Be following outcomes and more over time and using run charts or an interrupted time series design, looking at both process and healthcare outcomes. The process-based ones are the ones that would just kind of show, are we adhering to these guidelines? What percentage of patients have these items completed in the recommended 24 hours or 72 hours? And then some other outcomes to look at would be time and quantity of palliative care consults, the number of hospice referrals, and some other healthcare utilization outcomes such as ICU length of stay. What I'm working on now is hopefully starting to go to the key stakeholders, the people who would be impacted by this workflow, to understand their needs and the barriers. We're also working on finalizing these EMR tools for the ACS and trauma services. Specifically, the surprise question may be launched on our admission order sets as early as February of this year. And initially, it's really just to start collecting data and see who we're capturing with this question and see how it goes. And then there'll be a training program that the MSQ is designing that is going to be virtual, but I'm also working on really addressing the specific education needs of the surgical residents. And so residents, you may have seen a survey that I've been pressuring you to take, but I'd really appreciate your responses because it will help us, not only put in training for this program, but also help potentially create a tailored palliative care curriculum for the future. And finally, I put my grandmother, my Mimi here. She's turning 94 this April, and it felt important to put a face next to this statement that I knew. But the truth is she's actually undergone 2 major surgeries in her 90s and is still kicking it in Florida, in no small part due to the army of advocates she created by having 9 children and millions of other grandchildren. And she obviously provides a huge inspiration to me daily, but the real inspiration, like I said, for this project came from the patients that I see daily at UC Davis. All you need is to spend one night using the 5513 pager, and I guarantee you see a lot of our patients are in some stage of serious illness, if not many. They're frail, they are aging, they're unprepared. And while the golden ticket is goal concordant care, few know how to get there, few know how to measure it. But what we do know is 2 interventions seem to consistently help us get there. And that's earlier conversations with patients about their goals and greater use of palliative care. So I really appreciate the opportunity, Dr. Jurkovich, because this is a lot of hard work. It's going to take a team effort, a lot of buy-in from people and residents to carry this forward after my time. So thank you.
Thanks, Jen. I call on Misty Humphreys to make some comments, but as she is, I want to emphasize the issue of how important the surprise question is and how it can be applied throughout the department to help with our new quality initiatives, and would be a department-wide, as Dr. Maynard is online, a department-wide help in addressing some of our quality issues. Dr. Humphreys.
Yeah, Dr. Geiger has done just an amazing job with this project and kind of looking at the whole aspect of it. I have a really strong interest in dissemination and implementation science, and really that's where her project is a little bit more beyond quality improvement. And she's got an exceptional team. We met yesterday actually going over how all of this is going to be implemented and how things are going to roll out. And the health system is really behind this and has a lot of resources. So I think it's going to be great, but it doesn't just apply. We're starting in one particular area so we can refine the project with ACS, but it applies to all of us. I have frequently thought that every patient that gets surgery should have an advance directive, even the 22-year-old. Because if we take away the stigma of talking about death and what people want, then perhaps we can actually get to where we have the real conversations we need. And we're not quite there yet, but we're on the road to actually making sure that everybody is getting the care they want and they understand the care that they're about to receive. So I really applaud her efforts on all of this.
That's terrific. I think Dr. Maynard is logged on. Greg, are you on? Would you like to make a comment?
Yeah, thanks, Jerry. I just want to thank Jennifer for taking this on, and Misty. I think this is a great project, and it was very aligned, as you pointed out, with our institutional goals. And I think surgery, if you have areas where you have mortality opportunities, this would be an easy way to align with Vizient goals, to just simply follow this game plan and have mortality as your goal, and have those same measures that Dr. Geiger just showed around advanced care planning and referral to hospice, et cetera.
Perfect. All right, terrific. Dr. Geiger, thanks, Jen. Let's move it on to, who did I say? Ashley, I think, is next, please.
Perfect. Thank you so much for the opportunity. My name is Ashley Roth. I'm one of the 4th-year general surgery residents, and I will be presenting using 2020 COVID-era data as a simulation of a dedicated ACS OR to show the effect on time to operation. With this, the idea for this project actually started during the initial wave of COVID, specifically during roughly March 15th to April 30th. And it was during this time that elective cases were canceled at UCD. And it was subjectively noted amongst some of the ACS providers that cases actually more efficiently got to the OR. And it was sort of this idea and this implication that we really wanted to delve into. As we know, ACS is an evolving specialty. Specifically at UCD, ACS performs over 1,000 procedures per year, most of which are urgent and emergent. However, UCD ACS still does not have a dedicated OR. For a patient presenting to the emergency room that requires that emergent surgery, as we know, timing is critical to help reduce both morbidity and mortality. Urgent cases are unpredictable, and scheduling them can be incredibly complex. We've all experienced this complexity trying to get patients to the OR. Specifically from an ACS perspective, this complexity is due to competition with elective cases. This can cause delays, cancellations, patients being rolled to the next day, whether that's the elective cases or even our urgent cases. But there's also competition among other urgent cases in other specialties. And then, of course, we know that the complexity also is just due to there's only a finite amount of resources and manpower with all this. With this, the pattern of delays and cancellation not only slows down the OR, but it also adds additional cost. This is seen with longer length of stay. This is seen in the use of on-call teams. The delays that are seen in the operating room not only affect us surgeons, but it has a complete ripple effect throughout the entire hospital and can very easily overwhelm the hospital's resource system. However, there is good news, I promise. And with that, there have been other studies that have looked at this problem with tertiary referral centers and level 1 trauma centers that have noted by implementing that OR for urgent and emergent cases has actually helped alleviate scheduling emergent and urgent surgeries among elective surgeries. And they have noted decreased length of stay, decreased operations in non-daytime hours, and actually increase in patient satisfaction. During this sort of COVID era, elective cases were canceled, as I had stated, and the prelim data at this time shows that specifically cholecystectomies that we looked at were performed more rapidly. As a little background, most of us know any ACS patient that requires any urgent or emergent surgery within 48 hours is placed on the add-on board. It's no surprise that the urgency of these cases are divided up into 3 categories depending on how quickly they need to get to the OR, specifically red cases, yellow and green, red being that they need to get to the OR within 2 hours, yellow within 12, and then green within 24 hours. Previously, we just didn't really have the ORs to be able to facilitate specifically a dedicated ACS room. However, with new rooms coming, hopefully in July, and then further utilization of other resources of the children's OR, same-day surgery, and other sort of subspecialty suites such as GI vascular. There's a new opportunity, hopefully, to be able to implement this dedicated OR specifically for ACS. This right here is looking at cases for the last 5 years. On the left in the blue and yellow, you're looking at ACS cases specifically. And then over on the right, the black table is looking at cases for the entire hospital. And the 2 big things that I really wanted to point out to really just show how ACS is so different is one, the main portion of cases that make up all OR cases are elective cases. Not a big surprise there, but that's roughly about 75% that the OR sees. Comparatively, when you're looking at ACS cases, the majority of our cases actually fall within that urgent yellow group, so need to go to the OR within 12 hours, and this is just about 50% of our cases. In addition to the types of cases that are seen, It's also the timing of when these cases get to the OR. Specifically looking at all cases, only about 25% or so of the cases go within non-daytime hours for all cases. And that's outside of that, 07:30 to 15:30 timeframe. Comparatively, ACS cases, up to about 50% of our cases can actually go in non-daytime hours. So that's the utilization of on-call physicians, on-call teams, and using those limited resources at night for other emergencies that come in. This kind of just further shows that timing of cases. Again, this is looking specifically at ACS cases in the division of both daytime hours that you can see in gold, and then off time hours, again, outside of that 07:30 to 15:30 timeframe. And the two big things that I wanted to point out here were, one, over the last 3 years, that you can see that just the number of cases for ACS has increased. And then over the last 5 years, the number of non-daytime hour or nighttime operating has increased. And just within 2020 has increased up to 50%. So kind of with all this in mind, with all this data, what we really wanted to do is we compared the time to operation for ACS cholecystectomies admitted between 2016 to 2020 versus a COVID era to simulate having that ACS dedicated OR. Our thought was by having this dedicated OR, we would decrease time to operation and then also decrease length of stay. Our aim was to develop both a simulated model and then also a prospective OR model to demonstrate the impact of having this dedicated OR for our urgent cases. The data that we pulled initially, again, from 2016 to 2020, our initial poll was 1,043 patients. Of that, 411 were excluded. This was due to diagnoses such as gallstone pancreatitis, choledocholithiasis, and just kind of other patient factors. And these patients were excluded essentially because it prohibited them from the admission to OR. It created a delay that was outside of the hospital. But of our original patients, 632 did meet inclusion criteria, and of that, 10 were within our COVID era, again, that March 15th to April 30th timeline. Our endpoints to evaluation, the first was time to operation, and that was specifically time of admission to the OR. We looked at order to operation, and this is a little different in the fact that it was at time of surgical case request to the operation. And then additionally, we looked at things like length of stay and then also cost. As you can see, this is looking at hours to cholecystectomy, so that admission to cholecystectomy. And over the past 5 years, this has ranged from anywhere from 23 to 32 hours. However, during the COVID era, our simulated OR, we were able to cut that down to 17 hours to get patients from admission to OR, and that was noted to be statistically significant. Similarly, looking at hours from the time that the surgical case request went in to procedure was very similar. Over the last 5 years, it ranged from 13 to 24 hours. But again, during that COVID-specific time, we were able to cut it down to 8, again, being statistically significant. Kind of along this same thought, looking at length of stay, it was noted to be decreased over the last 2 years. We noted that the length of stay was 2.1, and it was approaching statistical significance, but we did not note that. Kind of big picture, COVID had created the opportunity to highlight the impact of a dedicated OR for ACS patients. A dedicated operating room appears to improve time to operation and may ultimately result in shorter length of stay. Then big next steps for this are actually threefold. We obviously want to take this forward, demonstrating the impact that this dedicated ACS room has on our patients and our cases. So we will additionally be looking at additional COVID-era data over the last several months. We will be doing a completely simulated OR. And then come July, when the new ORs open, we'll be doing a prospective review looking at patients going to the OR. The net result is what most can expect. With the implementation of this OR, our plan is to see a decrease in time to operation, decreased length of stay, and kind of big picture is hopefully to alleviate hospital overcrowding that we see so many times, and then decrease associated costs, and then also just an overall decrease in nighttime operations, leading to improved patient satisfaction and, of course, provider satisfaction. I just want to say thank you to everyone who has helped out. There are honestly too many people to name, but my mentors, Dr. Zapoluzny, Dr. Calcutt, all of the residents who have been 5513, and those who are to come, they know that this is truly a struggle, getting ACS patients to the OR. And then also a big thank you to Dr. Galante, Daniel Black, and Abby D. Graffenried. Thanks.
Thanks, Ashley. I'll let Dr. Calcutt make a comment. I do want to note, I appreciate you giving a shout out there to Daniel Black and Abby as great aids to us in data acquisition. They're really key to us in many, many aspects of our clinical practice. So thanks, Dan and Abby. Dr. Calcutt.
Yeah, so I just want to acknowledge and thank Ashley for thinking forward and taking advantage of some of this opportunity. You know, some of the best projects come from observing what's around you, and we recognize that we had a really interesting opportunity to do a true simulation study. Most of the work that's been done in this area before about the impact of the acute care surgery rooms has actually occurred after one has been implemented or as part of a business plan to implement one. And you don't often have the opportunity to see a natural experiment in process. And we, unfortunately, because of the pandemic, but fortunately also for us to really look at what the impact is. It's important to note that nothing is truly elective that we do. So when these cases were slowed down, it was that there was triage, which freed up some of the rooms. So we never fully stopped our elective practice across all of the various different surgical disciplines. But there was enough cases that were deferred to later on, either for patient preference or because it was felt to be something that could wait from a provider standpoint. It freed up enough opportunity for us to, even with a very small volume of cases, show a real difference. And so we're very much looking forward to seeing what the impact of this is. And this affects more than just acute care surgery. Lots of people do urgent and emergent operations, and I think that's really important. So congratulations to Ashley, and we're super excited about this project.
Excellent. Dr. Farmer, any comments on this one before we move to our last one?
No, I think it's excellent work and really look forward to it. I just added that we saw the same thing happen in cancer, where patients were able to get into the OR much faster, resulted in fewer delays in terms of chemotherapy and onset of other things. So it really just speaks to the need for increased OR availability to do the right thing for our patients. And hopefully we're going to get there soon.
A recurrent phrase for those of you who have been around more than 5 years. Keith, you're up. Dr. White, our fellow in acute care surgery and surgical critical care, will be our next presenter. Dr. Kokenauer is his mentor.
The Society of Critical Care Medicine created an ICU bundle of services that they labeled A, B, C, D, E, F. The goal of which was to reduce delirium, improve pain management, and reduce long-term consequences for adult ICU patients. Some of these consequences of deep sedation include decreased 6-month survival, increased hospital mortality, longer duration of mechanical ventilation, longer length of stay in the ICU, and increased physiologic stress. So Going through the A, B, C, D, E, F, the A is for assess, prevent, and manage pain, something we talk about daily on rounds on our ICU patients. B, strangely enough, is for both, and it stands for both spontaneous awakening and spontaneous breathing trials. So what we do is every day, we try to wake patients up. We interrupt their sedation. We try to give them a vacation from their sedation, and we try to do this in a protocolized fashion. We then perform spontaneous breathing trials to see if the patients are ready for extubation, and we'll perform weaning trials or T-piece trials. I'll cover the rest of them real quick. So C stands for choice of sedation and analgesia. So we try to go to non-opiates as much as we can. We try to use less continuous sedatives as much as we can. D is for delirium. And we try to daily assess, prevent, and manage our delirium. E is for early mobility and exercise. And F is for family engagement and empowerment. Previously, we've looked at data in our ICU, which showed that almost half a day passed from the time we performed and the patient passed their spontaneous breathing trial to the time where we actually extubated them. That was when we were in compliance with our bundle. If we were only in partial compliance with our bundle, it was basically an entire day. What I noticed when I started here was we performed many of these spontaneous awakening trials and spontaneous breathing trials overnight when the respiratory therapists have time to perform the trials. And they often do them at 2, 3 a.m. We then do not make a decision at that time to extubate the patients. And so patients then get sedated again, get their pain medications turned on again. So they're often, when we come to see them in the morning, they're back on propofol drips and fentanyl drips. And we then have to stop those again and reassess and see if they're ready for extubation. As opposed to, as soon as we do our spontaneous awakening trial and they pass their spontaneous breathing trial, making the decision right then and there to extubate and liberate the patient from mechanical ventilation. This has been looked at in multiple studies and showed that protocolized sedation and daily interruption appears to decrease mortality, appears to decrease your ICU length of stay, your hospital length of stay, as well as tracheostomy creation when compared to non-protocolized driven settings. So our goals, like I said, are to decrease the time from between passing our spontaneous breathing trial to liberation from the vent, as well as decreasing the amount of continuous sedation and decreasing the interim analgesia. The patients that we include in this are surgical ICU patients who are on the vent, who are adults. Our spontaneous breathing trial safety screen here includes the following: no agitation, SATs greater than 88%, PEEP of less than 7.5, no myocardial ischemia, no vasopressor use, and inspiratory efforts present. Patients that we do not include in this are patients who are post-cardiac arrest, who have been ventilated for over 2 weeks, who we are not committed to full support, and who have had profound neurologic deficits. It's not being said we don't try to apply some of these same concepts to these patients, but it's in less of a protocolized fashion. So the primary goals we're looking at are: how long does it take from when we pass our spontaneous breathing trial to when we extubate? Does this decrease the days of mechanical ventilation we're on? How long they're in the ICU? And mortality as well. And secondary outcomes include things like pneumonia. The longer you're on a mechanical ventilator, the higher your risk of pneumonia. So shortening that time should decrease your risks of pneumonia, as well as the need for tracheostomy. The premise is theoretically very simple. It's to have a provider who's able to make the decision to extubate available at the time of completion of the trial. So what we've been trying to do is move some of these trials from 2, 3 a.m. to later in the morning, 5 or 6 a.m., The fellows usually come around 6 a.m. so that when they pass, we can be notified and make the decision to extubate. If they do not meet the criteria, we then can further evaluate the reason for. Is it agitation? Is it pain? And if we can correct those, potentially we can repeat the process later that same day. So that is the premise of it. Thank you.
That's been a longstanding frustration, at least of mine, in that we're trying to help patients get sleep, which is also very important to their healing process. And so we've talked with respiratory in the past. And so hopefully by trying and move it to a little bit later in the evening, i.e. for them, so closer to the early morning hours when we can actually make the decision and not have the overnight residents have to feel like they have to make the decision to extubate. And especially when there are a few less people around, that's probably a safety concern as well. So we're hoping by trying to protocolize this a little bit more, we can actually do this and actually get our patients extubated in a more timely fashion and help promote sleep in our patients.
All right. Final comments from Dr. Maynard on the quality projects throughout the hospital. If Greg is still on, Dave had to leave at 8:30. I think he must have logged out. I want to thank all of the, first of all, I want to congratulate the residents and their advisors for putting together these projects and presenting them to us. It shows depth of what the department's about. There's a new initiative, an increased initiative at the hospital of quality, and you'll see more about that all year long and the reasons behind it. And these are some examples of how we as a department can help and move that needle forward a bit. We'll conclude with Dr. Farmer's last statements.
Now, outstanding morning, our virtual M&M trial. We'll work on Dr. Jurkovich's time management, and I anticipate that we'll be back in our hybrid form next week, but we will let everyone know ahead of time. And congratulations to the residents who presented their projects today. And there are several others that have been awarded support from the institution in the department, and very proud of the residents' work. So thank you all, and have a good day.
All right, bye everybody.